very comprehensive presentation. And we have to move to the next speaker. The next speaker will be Dr. Emad Magdy, a lecturer of nephrology from Mansoura-Nephrology and Dialysis Unit. And his title of his presentation will be about FSGS. Please welcome Dr. Emad Magdy. Dr. Emad, please.
Assalamu alaikum. Are you seeing the screen well now?
Yes. Yes, Dr. Emad, go on.
Okay. Thanks, Dr. Abdullah, for the previous lecture. You carry some weight from me. I'm now talking about the focal segmental glomerulosclerosis, revisiting an old entity. My agenda, I will go thoroughly on the light microscopic pattern. It is not a light microscopic pattern, not a disease, as Dr. Abdullah mentioned. But is the light in microscopy sufficient or not? What are the predictors of the outcome? The diagnostic evaluation and the evidence in management of FSGS. So FSGS is a histopathological pattern of injury by LM, not a specific disease entity. It is conventionally defined as the consolidation of part of the glomerular capillary tuft that's attached to Bowman's capsule, and in late stages contain an accumulation of extracellular matrix involving a subset of glomeruli. If we describe the pathophysiology thoroughly, we have an initiating event or supposed series. We will see multiple supposed series in the FSGS, but when we apply to the management, the picture will change. So we have an initiating event, which is the permeability factor, or maybe the gene mutation, maybe the viral injury, hemodynamic stress, immune complex, and then this initiating event will progress to injury at the cellular level involving the podocyte, causing apoptosis, impaired autophagy, detachment, and dedifferentiation. We have also the pathophysiology of paracrine effect, that the lesion and podocytes spread to the adjacent podocytes, and then upregulation of the signaling pathways in the hypertrophied podocytes involving differentiation and fibrosis, and at the last impaired healing. And this will lead to glomerulosclerosis and interstitial fibrosis. So if we simply doing some representation of this, it will be like this. The injured podocyte, no change in podocyte number, it will be minimal change, but FSGS podocyte detachment cause segmental sclerosis, or podocyte proliferation in high amount cause collapsing glomerulus. The LM of the focal segmental, Dr. Abdullah discussed the LM finding, but I'd like you to see this arrow. We all know that the classic paradigm for classification of the FSGS is the FSGS tip lesion, perihilar lesion, not otherwise specified, and the collapsing variant. And as you see here in this arrow, when you go to the bottom of the arrow, so the aggressive form, which is the collapsing variant, and rapid progressive form. When you go up, there is less progressing form and better survival with therapy. And the perihilar and not otherwise specified is are between them. So this is the classic paradigm, which it changed due to some thoughts. Number one, it is not only the light microscope which will judge the prognosis of the FSGS, because we have some studies tell us that we have different prognosis criteria for the collapsing FSGS with the not otherwise specified. And this is one of the published articles. See that the idiopathic collapsing FSGS presented with more severe nephrotic syndrome, and lower GFR, but had a similar renal survival after controlling for exposure to immune suppression. And these results highlight the importance of early diagnosis and the institution of immune suppressive therapy in collapsing FSGS. So this will take us to the significance of EM. One question, please, because I have a problem with my voice. Did you hear me well?
Yeah, you're doing great. Thank you.
Okay. The significance of the
Yes,
electron
Emad, we
microscopy.
hear you very well. Go on.
The significance of electron microscopy, you can determine this in those 3 points. Number one, the principal abnormality is a food process effacement have a variable degree between the different categories of the FSGS. That's number one. The immune deposits are not present, but trapping of IgM or complement within the segmental sclerotic area can be observed in the immunofluorescent microscopy. But we should know that the food process effacement can't be reliably assessed by examination of glomeruli with advanced glomerulosclerosis, and also will be not reliable if the patient on immune suppression and start to be partially improved. And this is how the electron microscopy can help us partially to differentiate between the maladaptive and the primary or the permeability factor induced focal segmental. Because in the we talk about the minimal change, but in the maladaptive focal segmental, there will be preserved food processes, some preserved food processes, but in the primary there was diffuse food process effacement. So light microscopy should be augmented by the electron microscopy, and for some reason, if we try to know what are the what are the drivers of progression, how can I assess my patient? Is the prognosis is only related to the histopathological presentation? The answer is no. Those are the drivers of progression. We have one item of them is the pathology, but the baseline GFR, the rate of deterioration of GFR, and the most important one, which is the response to therapy and the proteinuria reduction, the hypertension and its response to treatment, the hyperlipidemia, and a new histopathological target, which is the podocytopenia. We talk in the pathophysiology that the focal segmental is a pathology of detachment, partial detachment of the podocytes, and then will cause podocytopenia. And podocytopenia is an early marker for glomerulosclerosis. So it is not only histopathological. It is a mix from light microscopy, electron microscopy, and the clinical, because we don't have any ideal surrogate marker for the progression or the severity of the FSGS, and also we don't have surrogate marker for differentiation between the categories of the FSGS. But the response to therapy and proteinuria reduction is the most sensitive for determination of the progression. So what are the categories? We have some shift in the differentiation. This is the classic one, which is the genetic APOL1 primary virus associated, indication toxin associated, to less categorized, which is permeability factor related FSGS, genetic FSGS, secondary FSGS, and FSGS of unidentifiable cause. I'll pass to take some small hints about each category of them, and I will concentrate on the clinical implication of each type of them and the clinical natural history of each type of them. The first one, the previously known primary FSGS, newly known the permeability factor related FSGS, is a diagnosis of exclusion. Also heterogeneous in pathogenesis, closely related to the minimal change. Supposedly it's caused by the injury from permeability factor, but really there is no clinical or there is no clinical significance of measuring the permeability factors in the serum to know the prognosis or the extent of injury, because the full prone picture of the molecular and serum mechanism of the permeability factors are not completely understood. It is not single disease entity, and till now there is no, as I mentioned, there is no diagnostic or prognostic implication related to the permeability factor measure. The clinical implication, this form is most commonly associated with nephrotic syndrome, non-selective proteinuria. The immunofluorescence may be indicative for prognosis because IgM C3 deposits and sclerotic lesions may tell me something about the prognosis. And the electron microscopy will be usually diffuse effacement in an intact glomerulus during active nephrotic syndrome, because as I told you, in the electron microscopy, we can't judge the full process effacement in sclerosed glomerulus. I will talk about the secondary in the next more slide, but here to just make the clinical discrimination. So in the primary, if I have sudden onset of the disease, that is insidious onset, the proteinuria usually nephrotic, here typical non-nephrotic. The albumin sure will be affected by the proteinuria. The full process effacement will be diffuse, here will be focal, and then we will talk about the treatment further in the presentation, inshallah. Why I mentioned this? Because this is now some way of helping me to diagnose the patient and start to approach the patient, start to treat the patient. So if I have FSGS lesion, and which this is nephrotic syndrome, yes, primary. If it's non-nephrotic, I'll think again, electron microscopy, widespread or diffuse, I'll think again. So this is a second category, which is a primary or permeability factor induced. The second category is the genetic induced FSGS. Up till now, we have around 55 or 60 genes claimed in the pathogenesis of focal segmental, but the most important of them are the slit diaphragm proteins and the glomerular basement membrane proteins. Those are the most studied protein panel, gene panels for diagnosis of FSGS. And here, again, those are the genetics or genes implicated in the genetic kidney disease. In the glomerular diseases, you will find the col4 A3 and col4 A4 and col4 A5 are the most implicated genes in the glomerular disorders, genetic glomerular disorders. So what are the implications or the clinical implications of the genetic FSGS? Sure, the presentation more commonly in children, not in adults. In adults, around 15 to 20%. It can take any type of genetic transmission: autosomal dominant, autosomal recessive, X-linked disease, de novo. So it will take all the patterns of the genetic inheritance. There may be some genetic susceptibility to secondary FSGS, obesity, viral infection, and COVID. And this is very important because while I'm talking to you about the implications, how to approach the patient, I'll tell you that the patient may take some forms or some categories, more than one category in his life in the progression, or it can be confused in a situation like this, because you can even have a secondary FSGS because you are genetically susceptible to this. And in children, the screening is recommended, but in adults, it should be specified to the steroid-resistant and syndromatic presentation and the clear family history of the problem. And this is the indications, the main indications of the genetic testing. So if I have non-nephrotic syndrome and diffuse food process effacement, I will do genetic. Nephrotic syndrome and diffuse food process effacement but resistant to treatment. Nephrotic syndrome or non-nephrotic syndrome with segmental focal food process effacement, and no evidence of secondary cause, I will do a genetic test. The third category is the secondary FSGS. Secondary, we have, we all know that it's mostly due to viral infections, due to drugs, and we also have the category of the maladaptive due to obesity or a problem in the hyperfiltration or renal agenesis or nephron loss. Multiple classifications. And in COVID, sure, we see the multiple association of the COVID cases with collapsing FSGS. The collapsing FSGS is not only related to, as we all know, to the IV drugs or to the viral infections. It is now associated with malignancies. Very much, those are the case reports within the previous year only. So it's expanding, and the collapsing is nearly to take around to take another pathway away from the FSGS, which is the collapsing glomerulopathy. The clinical implication, I talked to you about it before. So the non-primary, genetic or secondary, are notable for tendency for slow progression, non-nephrotic proteinuria, and normal albuminuria, and by resistance to steroid treatment because it is not immune mediated, as Dr. Abdullah said, and very low risk of recurrence in renal allograft, and this is very important in the transplant decision. So if we try to approach the patient, as we see, this is the summary made by Dr. Richard Glassock. This is a combination of the onset of disease, extent of proteinuria, finding in light microscopy, and extent of food process effacement. And this is what can be a summary of what we said in the previous slides. The degree of effacement, the light microscope pattern, and the clinical presentation will judge. So let's escape to the lines of management. And in lines of management, we have multiple theories and very low evidence. So theory versus evidence. Why this discrepancy between the theory and the evidence? Because we have this dilemma of evidence. Number one, the lack of animal models that are representative for all the categories of FSGS. This is a challenge. The challenge number two, that the available trials were not all including the electron microscopic histopathological assessment. And we discussed how it is important. Challenge three, that the available trials were not all including the genetic testing. There is no unified definition of steroid responsiveness in trials. We all know that in the guidelines now, we know that we are treating the patient for 16 weeks, but this is not reflected to the trials. Not all the trials are doing the steroids for 16 weeks, some of them 8 weeks. So those are the challenges to have good evidence in the management of FSGS. Regarding the treatment categories, I'll take it by this way. I have main 6 targets for the drugs that treat the FSGS. Number one is to target the permeability factors, which is already sensitized. Target 2 is to suppress the permeability factor formation. Target 3, targeting the hemodynamic abnormality, targeting the genetic mutations, protecting the podocytes and promoting regeneration, and targeting the inflammation and fibrosis. In this category, in first category, we have some known trials for free galactose and plasmapheresis and immune adsorption and CD40 antagonism. I will discuss it in summary. Like this one, targeting the permeability factors, we are using to remove or inhibit the action of permeability factors underlying the primary pathology. We don't have strong evidence except for the plasmapheresis in the management of post-transplant recurrence of FSGS. We have the selective LDL apheresis, the unselective immune adsorption, the free galactose. All these are relying on the theory of non-selective removal or immune adsorption of all the permeability factors, but we don't have any strong evidence for this. We have only one randomized controlled trial on the galactose, because the galactose has been reported to bind and inactivate the permeability factors, but the number is very low, and the trial is of low evidence. CD40 antagonism is also a strategy to bind and to decrease the effect of the permeability factor, but still we don't have results, good results or high evidence results. So if we take this option from the evidence, we don't have only evidence except for plasmapheresis in the post-transplant recurrence. The galactose, the immune adsorption, the CD4 antagonism, we don't have much evidence. For category 2, which is suppressing the permeability factor formation, this is the most important evidence we have. So we have the glucocorticoids, the CNIs, and the rituximab. Those intended to interfere with the innate or adaptive immune response and suppress formation of permeability factors. And we all know that the only standard treatment for FSGS in the glucocorticoids and in resistant cases is the CNIs. Steroid responsiveness is specific for the primary FSGS. So as Dr. Abdullah said, it is autoimmune related. So the possible action of steroid will suppress this, but the steroid resistance is not sensitive to differentiate between the other subtypes. So if it is steroid responsive, it is sure primary or permeability factor induced. But if resistant, it can be resistant permeability factor or other causes like genetic or second. Rituximab is quite less evidence. Rituximab may reduce the elaboration of permeability factors. However, patients with steroid-resistant FSGS usually also fail to respond to treatment with rituximab, and also the rituximab is also reserved to the post-transplant recurrent FSGS. So if we try to summarize the evidence after all the theory, the glucocorticoid is the first line therapy and should be given for at least 16 weeks. CNIs for the contraindication to steroid or resistant to steroid, rituximab for the post-transplant recurrence. Category 4 is targeting the hemodynamic abnormality. So biologic, those two are for the primary because they are acting on the permeability factor. For this one, it's targeting the hemodynamic abnormality. And sure, this will be for all, but mostly to the maladaptive and to lesser extent to the primary factor. The main two players here are the RAS inhibitors and the endothelin antagonists. We have two drugs, the RAS inhibitors and the RAS blockade, and the endothelin antagonist. And if we revise the evidence, we'll find that RAS inhibition non-specifically attenuate proteinuria in all forms of FSGS, but least effectively in the permeability factor induced. Sparsentan is preventing the disruption of actin cytoskeleton, and we have a study which tell us that it's beneficious, but it is on low proteinuria patients. We have now ongoing a study and its extension of DOT, which make categorization of the patients. Because in the first study, there is no categorization, FSGS non-categorized, but they are working now on a categorized study. So to summarize this part, so RAS inhibition for all, permeability factor induced, and the sparsentan waiting the result of the ongoing studies. Targeting the genetic mutation, sure, it will be in the genetic induced FGS. We have gene silencing strategies, stem cell therapies, but all are under ongoing clinical trial. The issue number 5 is protecting podocytes and promoting regeneration and targeting inflammation and fibrosis. And sure, those are for all the patients with FGS. The protection of the cytoskeleton, slit diaphragm protein control, activate apoptosis and restore podocyte markers after injury, and maybe T-cell inhibition. And those are the drugs. You will see here that glucocorticoid and CNIs, beyond their immune suppressive action, they have direct beneficial effect on the podocytes. But this rule is theoretically, yes, proven, but clinically not proven, because we have patients on the have recurrent FGS after the transplant, and we all know that all the post-transplant protocols are relying on the glucocorticoids and the CNIs. So if they really have clinical significance in protection, so why the patient come with recurrent FGS? Rituximab, ACTH, abatacept, mesenchymal stem cells, all these are still under trialing, and we don't have strong evidence about this. So again, very weak evidence. Targeting the inflammation, this is the future. We have more than one inflammatory pathway targeted to suppress the inflammatory and profibrotic component of the FGS lesion and modulate the glomerulointerstitial scarring. We have here multiple pathways targeted. All again are in the level of experimental studies or ongoing clinical trials. So this is the summary. So if you here revise the category used and the evidence and significance, you will find that sure, the targeting the permeability factor and suppressing permeability factor is permeability factor induced. Targeting hemodynamic, all mainly adaptive and to a certain extent permeability factor, genetic, and those for all. But the evidence, we don't have here evidence except in rituximab for post-transplant. Here, the most weighted evidence, lesser evidence, running, there's no evidence yet. Again, rituximab in post-transplant, and here is running. This is a summary of what I made the last time. I think Dr. Abdullah covered this part. This is my last part, which is the approach to manage. Again, the glucocorticoids is the first line of treatment, but we should know that the response is related to the time. So if we take the response and the response rate after 12 weeks, it's quite low than after 16 to more than 16 weeks. So the response to steroid will take some time. But I should determine at first, is it usual, is it mostly primary or not? So primary with subnephrotic proteinuria, I'll give RAS inhibition and dietary sodium restriction. Primary with nephrotic or nephrotic range proteinuria, I start glucocorticoid. If it's glucocorticoid resistant, I'll pass to calcineurin inhibitor. The adaptive FGS, sure, RAS inhibition would be the first and dietary salt restriction. The secondary, just treat the cause. I think I'm run out of time, so I can, those are the clinical guidelines, how to taper, how to start, and the recommendations of the calcineurin. I'll just skip to the last issue, which is the follow-up and remission and progression. This is again the axioms of Dr. Richard Asuk. You should know that the recurrence rate after transplantation is very high in the primary, low in maladaptive, and low in the undetermined cause. The response to RAS inhibition is poor here, excellent here, and good here. Glucocorticoid and CNI may induce remission, ineffective and harmful, ineffective. So it's not effective except in primary form. Just knowing what is the remission, what is the terminology, what's the complete remission? Complete remission is reduction of proteinuria below 0.3 gram or unstable serum creatinine. Partial remission reduction between 0.3 to 3.5, and relapse is proteinuria more than 3.5 after complete remission has been achieved, or increase in proteinuria by more than 50% during partial remission. And this is a steroid resistant, steroid dependent, CNI resistant, and CNI dependent. You'll see here in the steroid resistant, less than 50% reduction for at least 16 weeks. Steroid dependent, relapse occurring during or within the 2 weeks of completing the glucocorticoid therapy. CNI resistant, below 50% reduction for 4 to 6 months. And CNI dependent, relapse occurring during or within 2 weeks of completing cyclosporin or tacrolimus therapy. And thank you. I'm sorry for the voice because I have a problem with my larynx. I don't know why. I'm very sorry.
Thank you very much, Dr. Emad, for this comprehensive and elegant presentation about the FSGS. I think you already prepared the background for Shuru to present her case. But before moving to the case presentation by Dr. Shuru, I would like to welcome Professor Peter Sawaya, who joined our event. Professor Peter Sawaya is a professor of nephrology in Kentucky University, is an editor of Clinical Nephrology Journal. And I think he has a question or comment regarding Professor Abdullah Gira presentation about podocytopathy. So if he can join us, and if he can ask his question, please.
I think Dr. Sawaya was with us, but he just maybe disconnected for a moment.
Okay, can you ask his question, Mamdouh, please?
Okay, so his question, I think to Dr. Gira was, when steroid is used with CNI, do we use milligram per kg for dose, or we use target blood level of CNI?
Okay, when you're using the calcineurin inhibitor, usually we start weight-based, but we target specific blood level. Meaning, for tacrolimus, you target 5 to 7. For cyclosporin, you keep it around 150, between 125 to 175. But the reality is that it's different from transplant patient. So when we start, this is what the guidelines say. What I mentioned previously was what the guidelines say. What I do in my clinical practice, I usually start with a low dose. So I usually do like 1 or 2 milligram of tacrolimus twice daily, and I follow the proteinuria. As long as the proteinuria is good, I do not cut back. I do not just keep on going up on the dose until the patient reached the target level. It's different from the transplant where you always like to keep them in this therapeutic level. And in these entities, as long as you have control of proteinuria, you don't need to get them in this very high therapeutic level. Sometimes you can control the proteinuria with level of tacrolimus, trough level of tacrolimus of 2 or 3, or sometimes undetectable. So
I think I think this is a very wise approach, because we all know the chronic CNI toxicity, and we have confronted with cases from the long-term use of CNI toxicity in nephrotic syndrome patients. So I think it is a very wise approach.
do you have time for a comment on Dr. Magdy's presentation, or we're short on time?
Yeah, we can have your comments. If you have any comments, please go.
No, Dr. Magdy, I think you presented a very tough. I mean, when I'm asked to present on FSGS, I just try to find a way out, because FSGS is this topic that, as you presented, it's this heterogeneous pathogenesis for the same histologic picture. And as you pointed out, we run into a lot of problem of categorizing these patients. And most of what we see as data is very hard to interpret because of the fact that you cannot tell if we do not have any clinical tools to categorize these patients. I can tell you that we recruited to a ton of these trials, and endothelin inhibitor looks a very promising therapy. One of the challenge, if you mentioned this about categorizing these patients in the primary and secondary, even for endothelin therapy, the way you rely on putting these patients as primary or secondary or hyperfiltration is based on a clinical assessment of the provider. So that will create a lot of problem when this data is out to know exactly these endothelin inhibitor, which subgroup of FSGS that will help the most. They're gonna I think they're gonna go after FDA approval for primary FSGS, where most of the patients that they recruited are secondary FSGS, like you mentioned, hyperfiltration, because that's where it does work the most. So we still have a long way to go with FSGS. So very good job, but it's very hard topic.
Thank you. And all most of the clinical trials on the primary FSGS, they are including inside their inclusion patients with subnephrotic proteinuria or non-nephrotic proteinuria, which is a great argument against the present to be a primary or primary factor related.
Correct. That's 100% correct.
Thank you.
Okay, thank you very much for your comment. Because we are a little bit short of time, we'll move to this case presentation. The title of the case